Good morning.
Welcome to today's session. I want to welcome all of you. Thank you for taking your time and for sparing your humble time to actually join with us today. On behalf of SPEAR, Sun Pharma Education for Advancing Pharmacy Roles, I warmly welcome all professionals and all healthcare practitioners who've joined in with us today. Thank you for taking time out of your busy schedules today to participate in this important CPD accredited webinar. Today's topic is highly relevant to everyday pharmacy and clinical practice. PPIs, Therapeutic Mainstay in Acid Peptic Disorders. Tonight's session promised to be insightful, practical, and clinically enriching. Having said that, allow me to, at this juncture, to confirm to members that today's session will be special. On behalf of Sun Pharma, we have a lot of goodies. We have a lot of surprises. We will be having an engaging session. We will be having some random questions which we will be asking to participants or to members today. So please be keen, be attentive. So we will be posing in some polls, some questions which only your speed which will dictate if you're going to win at the prize. Every question we will be having a minimum or a maximum of 5 winners. So the top 5, dependent on how fast you will be with typing your answers in the chat box, will actually dictate if you are going to be the winner of today. So the awards which will be confirmed to us by the Sun Pharma representatives. So please stay tuned. We are about to have a very engaging sessions as we learn more about proton pump inhibitors today. So a quick one, just on some housekeeping rules. I would kindly request all of us to have our mics on mute session. Let them be muted so that we can actually have a comprehensive flow in this meeting today. When it comes to submitting your questions, kindly do so through our chat box. We will be actually combing through them and asking them, and your questions will be well answered by whoever is responsible for the specific question. And also we will be having a Q&A session after the Sun Pharma have actually done with their presentation. We'll be having 2 sessions. The speaker will be doing the presentation. He will be taking us through today's topic. After that, we will be inviting Sun Pharma who will actually come to do that. So let's actually be on the lookout to see how this goes. So at this juncture, guys, before we proceed, allow me to take this opportunity to welcome KPA Rift Valley Branch Chairman, karibu sana Chairman Douglas Omosa. Welcome so that you can talk to us. Karibu.
Thank you so much for the opportunity. I hope I'm loud and clear. I'm on the road.
You're loud and clear.
Thank
Just
you.
requesting whoever's mic is open, you can mute kindly.
Oh, great. Thank you. So now, good evening, members. Mine is not much. I just want to say you're most welcome to this particular meeting, and special thanks to Sun Pharma team for such a great organization. Also, looking at the topic today, I'm hungry and looking forward to learning as the rest of us. So I wouldn't want to speak much, but I would want to give this opportunity to the branch executive for the Rift Valley branch to also have a word, just an introduction, and for the interest of time. I can see Julius Nyakang, you've joined. Now I have the mic and introduce the rest. Thank you.
Good evening, colleagues. I want to believe that you have had a good day this morning to the moment. So indeed, we are very much honored to be here. also to learn. So we don't take this opportunity for granted. Thank you, our partner, for this wonderful opportunity to let us learn more from you. Thank you, back to you, Chair. The organizing. Hello, Chair.
Sorry, I lost you, but I think I'm back. Yes, thank you. Thank you so much, OS, for that. May I hear the deputy chair speaking? Anne Gadoni, second.
I don't know. Good evening, ladies and gentlemen. I wish to welcome you all into this meeting. I wish to appreciate Sun Farmer for the partnership. I'm sure we're going to have a very engaging and an opportunity to learn about JAD management. So everybody feel welcome. Let's participate. We have been told there are goodies that we are going to get from this session. And feel at home at Rift Valley. Thank you and good evening.
Thank you so much. The Deputy Chair, Rift Valley Branch. Now this mic goes to the Deputy Secretary, Rift Valley Branch, Charles Njoroge.
Good evening, colleagues. I hope I'm audible enough.
Yes, you are.
Yes, mine is to thank Sun Farmer for their kind gesture to plan for us this opportunity to learn. I welcome all the members as we add to what we know. In every crowd, there is a silver lining. So in every topic that we are learning, we will hear something that we have never had at some point. So I welcome everyone. Let's learn together. Thank you.
Thank you. And finally, let me welcome the Secretary of the branch. Victor, if you are in a position to speak, we had spoken earlier. I hope you are.
Thank you, Chair. Please confirm you can hear me.
Sure.
Thank you so much, Chair, and thank you so much to the Sun team. Good evening, colleagues, ladies and gentlemen. I am excited and delighted to be joining you this wonderful evening from Naivasha, Nakuru County, and also very grateful to Sun. We had a very in-depth discussion and learning the other day in Nakuru County, and we appreciate you for working together with us. And we look forward to ensuring that as we learn, then we are able to support you so that you get return on investment. To my colleagues, it's also my prayer that the knowledge gained is going to be beneficial to our practice, and it will help the public to gain and to see that we are more valuable. We are not only dispensing, but we are also able to offer counseling based on the information that we gather, so that we are able to give more empowered information. So karibuni the class and make it a lively, very best, and I'm looking forward to learning. Thank you, Chair. Back to you.
Thank you so much, Victor. So the the Secretary, Rift Valley Branch. Mine is, we've concluded. Now we want to have enough time for this conversation that is ahead of us. But a quick announcement. I see over 600 members in this team. And I know the main agenda of coming to this meeting is to learn. But I also know we have the continuous professional development token for you to be able, to renew your license at the end of the year. So my announcement is that what we normally do at the Rift Valley branch, we award you the token directly to your portal. Let that sink well so that we align. So all we are asking is, by virtue that you got to this level by registering your name here, We also assume that you've also done the same on the portal. Just search PPI, or you can search Vale, and then the event will pop for you to be able to subscribe. It is important because I know soon after this meeting, we shall start the journey of awarding the points. And we all know, for some of us who have done it, for those who are here and have done this, it's quite a tedious job. So we wouldn't want to do the back and forth kind of exercise. We just want to do search your name or your number, whatever way we do it, for us to be able to award you as soon as we get the complete list of attendees. So that is it from me. I want to hand over the mic to Dennis, to Bernard, sorry, to continue. Thank you so much, and have a happy learning.
Thank you so much. Thank you so much, Bwana Chair. The communication has been well received. Just to reiterate to all the members joining us, the 719 members. So I want to officially confirm once again to reiterate, today's webinar is officially on the PPB portal. So in case you haven't gone on the PPB portal, please head there and ensure that you subscribe. Remember, nowadays, we have limited times, like 7 days, to be able to do so. So please, please, please ensure that you officially subscribe on the portal, so that as the points will be awarded automatically through your portal, you will actually stand an opportunity to have those points awarded to you. At this juncture, allow me to welcome Mr. Bernard to take us through a session a small session which I had actually hinted to when I was doing the introduction. So Bernard, karibu sana. We are so happy to have you here.
Thank you, Dennis. Thank you, Dennis. Once again, good evening, everyone. My name is Bernard Kipngeno. I work with Sun Pharma. We are very delighted to have you all today in this Peer 6 program. This is a series of webinars which we are having to enhance our knowledge and sharpen our knowledge that we serve our patients better. We at Sun Pharma, we are really proud and humbled to have this partnership with KPA in ensuring that we are able to really enrich and enhance the practice of you at your facilities. And so this is Spear 5, and this is it's been a learning experience, I think, from Spear 1 when we talk about pain in adults, then we talk about pain and fever in children, then we come to Spear 2, Spear 3, Spear 4, we were talking about iron, and we really touched about iron in expectant mothers and iron in children. So it's been a learning experience, a learning journey, and I believe that your practice is being impacted positively. And so today, with this particular Spear 5, we are touching on a very, very important topic, that is PPIs. Studies have shown that up to almost 35-37% of the general population presents with GERD or reflux. So it's an indication or something which is quite common, and I think they could be presenting even at your counters. And today, as Dennis had alluded, that it is going to be a different kind of Spear series. And today we are having some polls and polls questions. You stand a chance to win something amazing even as you answer the polls. And so without much ado, I want to just jump straight away to the first question which we are going to have, and probably I'll just give a brief in terms of how to play and how to win. So I'm just sharing my screen. Just confirm if you're able to view my screen.
Yes, your screen is on.
Right. Now, this is a Spear series question and answer poll, and I think we in this particular Spear 5 we'll be having 7 questions will be spread throughout the talk, and we are going to have it in such a way that we want to see people just answering the poll question on the chat box. The top 5, the fastest people who are able to type in the correct answer to the questions, you stand a chance of winning internet bundles just to help you access more information, more content in the internet. So we'll be gifting you an airtime of 250 shillings. So the first question, which we are talking about, and it's just an extension of what we had in Spear 4, Spear 3, when we were talking about iron. And the question is, what is the amount of elemental iron available in ranferon syrup? What is the amount of iron, elemental iron, available in ranferon syrup? And if you remember our Spear 3 and 4, we were talking about iron. So if you can be able to type your answers on the chat box, that will be great. The amount of elemental iron in, I can see 200, I can see 200, 1.5, I can see 200. We are picking the first 5 right choices. So you have a chance of winning. I can see almost, if you've not sent the amount of elemental iron in ranferon, and this is very, very important in ensuring that your patients who are presenting with iron deficiency anemia are getting the maximum amount of iron, which we are offering through our ranferon syrup. Immediately after this, we are announcing the winners for the first poll. I'm just asking my colleagues here to just give me the answers. If we come out to tumefikisha tano, we close, then we hand over to the speaker so that he can be able to take us through the topic of the day. So we have room, amount of, kama uko kwa chemist, you can still even refer to the bottle at the shelf of ranferon, just to ensure that you are getting the right answer. If we are 5 already, I'll just want to, yes. So I'll just want to project the answer to this. The correct answer for the amount of elemental iron in ranferon is 41 milligrams per 5 ml. I think we have quite a number of answers, and I'm just announcing the first 5 who correctly mentioned this. We have Doreen Ochieng, thank you. We have Cecilia Mutungi. We also have Beth Njeri. We also have Beth Kiarie and Frida Nyaora. So these are the first 5 of our winners today. Thank you. And just to reiterate that we have the ranferon syrup gives your patients the highest amount of elemental iron. And so you can confidently recommend and even prescribe. At this juncture, I want to hand over to our moderator to be able to introduce for us a speaker who can be able to take us through the topic of today. Stay tuned because we still have 6 more questions and 250 watt of airtime to be won in terms of internet so that you can access more information on the net. Over to you, Dennis.
Thank you so much. Thank you so much once again, Bernard. So guys, if you're joining us right now, clearly, as you've just seen what has just happened, there's a lot of goodies for you. Today's session is going to be nothing like what you've experienced before. We are going to be learning, but at the same time, interacting and also getting some awards for us being stayed tuned in this session. So continue staying tuned as we continue with this session. So at this juncture, allow me, it's my great honor and privilege today or tonight to introduce tonight's speaker. So we are joined by Dr. Alex Makau Muia, who is a distinguished family physician affiliated with the Aga Khan University Hospital based in Nairobi. So Dr. Muia holds an MBCB and MED qualification and has extensive experience managing gastrointestinal and acid-related disorders in the clinical practice. So ladies and gentlemen, kindly join me in warmly welcoming Dr. Alex Makau Muia. The way we do it here virtually, we actually do that using some fire emojis. Let me see you type some emojis there as we welcome Daktari for today's session. Daktari, karibu sana. Let those emojis come, let them come. Yes, Daktari, those ones are for you. We are giving you props as you join us tonight. Karibu sana, Daktari. The session is officially yours. Karibu sana.
Thank you, Dennis. Let me share my screen. I'm happy to be joining you this afternoon. Just a minute so that I can share my screen. Okay. Good. I am hoping everyone is able to see my slides.
Yes, yes, we can see your slides, Daktari.
You can
Okay,
put it
okay.
on slideshow, Doc.
Just
Correct.
confirm my slides are moving.
Yes, yes.
Perfect.
Okay, good. So good afternoon, good evening, each one of you. Sorry for the delay. There was a bit of challenges in the clinic. So I'm still in the clinic. I've not yet gone home. So today, this evening, we are going to talk about one of the commonest GI conditions, and that is gastroesophageal reflux disease, which mostly it's managed in the primary care settings. So as you sit in your clinic, in your pharmacy, wherever you are consulting, definitely not a day you'll see a patient with GI problems, and mainly gastroesophageal reflux disease. So that is our condition we are going to talk about this evening. And usually gastroesophageal reflux disease is classified as or defined as heartburn symptoms or complications which result from the reflux of gastric contents up into the esophagus, and to some patients it can go all the way to the oral cavity and also the nasal cavity. So as I've alluded earlier, GERD is usually one of the commonest conditions which is not well managed, not recognized, and what usually come to the hospital or go to the specialist, that is the gastroenterologist, usually the tip of the iceberg. And most of these patients are the patients who have chronic persistent symptoms, patients who have complications which require intervention. Then in the primary care setting, or in the primary care, physicians, doctors who see these patients, clinicians, frequently you'll see these patients with, they just come with heartburn. They'll tell you they have some bad taste in their mouth. If you're keen, probably you'll pick it is a reflux disease. Majority, and that is where we want to target, those are patients who don't seek medical attention. And most of them, they may just present to you in your pharmacy or in your practice with just upper GI or upper abdominal discomfort. So as you can see, this is a condition which is widely not well recognized. So in terms of GERD, we have further classification into two subgroups. We have the non-erosive reflux disease and erosive reflux disease. And most of the time, the erosive reflux disease, those are the patients who will come to the hospital. They will present to or will be referred to the specialist. Non-erosive, most of the time, when we see these patients in a primary care setting, majority of the time we do dismiss them as upper Napale syndrome people. So because they do not have very clear symptoms, they'll come with heartburn. They just tell you they feel some discomfort in their chest. And again, when they get endoscopy or you get to do further imaging, you don't see any ulcers. So they are told your endoscopy is normal. And those are the patients who will end up being mislabeled, mismanaged, labeled as malingering patients, and since they have a problem. So that is usually one of the challenges we have, because they do not have any physical findings when you do endoscopy, when you do imaging. Then we have functional heartburn. So this falls under endoscopic negative disease, but usually differs from GERD by just being presenting atypically, because there are the typical symptoms of GERD, where when patients come to you, they tell you they have this central chest pain, or they have heartburn, and they are feeling something bitter coming all the way to the mouth. At least that one is straightforward. But functional heartburn is where patients try to present atypically. Even these patients might present with chest symptoms, just a cough. This chronic cough, which is not going away. And in these patients, they get usually mismanaged because their symptoms are not typical of what we are used to, as what we've discussed. And for you to say someone has a functional heartburn, at least you have proper history, and all those tests or the screening is negative. And then for you to label someone as functional, they usually have symptoms at least for 3 months since the onset of the symptoms to diagnosis. So this is more of the way we usually do the psychiatric diagnostic symptoms, where the symptoms have to be there for some time. In terms of the epidemiology of GERD, in outpatient setting, which is majority of our patients here locally we see in the outpatient or ambulatory setting, you find GERD from studies account for about 17.5% of all the digestive diseases recorded. So you see that is like every 2 patients out of 10 patients presenting to your outpatient, they have GERD. So that is how common this condition is. And it has a significant impact on both direct and indirect healthcare financing. Directly because GERD is a chronic condition most of the time. So patients will require long periods of coming to the hospital, being on the medical management or even surgical management. So they usually hit a good chunk of both time and also finances for our patients. Indirectly, especially where we have misdiagnosis, especially those patients who have an erosive GERD, or patients who are not able to afford imaging or endoscopy, because I think endoscopy in our setup is a bit expensive. So it's out of reach in most of our patients. So at the end of the day, they are treated or they are investigated for other things, especially chest pain. Because right now, if someone comes to you and says they have chest pain, the first thing you think about is usually not GI issues. You're thinking of heart attack. Most of the time, you'll think of heart attack. And you'll start doing ECGs, you'll send for echo, you send for cardiac MRI, chest CT. So again, going back to the basics, just take a good history, have a high index of suspicion for these patients. We said it's quite common. Every 2 in 10, that is quite common. So this is one of a recent systematic review, and systematic review usually form the hierarchy of evidence is usually high up there in the pyramid of evidence. So there was this, although this was done in North America, where they found between 18 and 27, that is almost, let's say, like 20 to 30% of the patients in the North America, that is the US, Canada, have GAD. Europe, you can see again almost the same number, up to around 26%. East Asia seems to be a little bit on the lower side. And when we move on in the later, you'll see the risk factors for GAD. One of it is obesity, and obesity is more common in the American population, also Western Europe. The Middle East, again, you can see it's quite on the higher side. So again, demographic and other associated factors will contribute to that. Then we do not have much data for Africa. So I think that is something we need to explore. In terms of the clinical manifestations, the cardinal symptoms of GAD are troublesome heartburn. So most of the time patients will just tell you, I have this indigestion or heartburn, which is not going away. I've tried to wait on it. I've tried to maybe check on my diet and it's not going away. So that should be one of you suspect GAD for these patients who have heartburn, which is not going away. The other one is usually regurgitation. So some patients will tell you, usually when I feed, after some time, I feel like that food is coming back. I feel some funny taste in my mouth. When I sleep, when I wake up in the morning, I get a bit of some food stuff or just water brush, all those regurgitation symptoms. And then heartburn is usually caused by the contact of refluxed material with already sensitized just a minute. Yes. With sensitized or ulcerated esophageal mucosa. So usually for esophageal mucosa, it's different from the histological mucosa of the esophagus and the stomach is usually different, because esophagus, the only job is it's a passage of food from the mouth into the stomach. So the mucosa is usually just simple columnar, just very sensitive mucosa. But when you go to the stomach, because the environment there is quite acidic, so it has adaptive mucosa, where it has stratified layers. It has several layers, and on top of it we have the mucosal layer, which is protective. But when it comes to the esophagus, it lacks that protective layer, and that is why that acidic food, when it comes up, when it regurgitates, it coming up, or the reversed peristalsis, you get ulceration, you get a lot of inflammation, and that inflammation is what gives the patients the symptom, where they say they have something burning, like in the central chest or coming up all the way to the mouth. And again, heartburn mostly occurs during the postprandial state. So most of the patients, once you probe further, they'll tell you mostly once I feed, and especially with like the evening meals, the dinner, because I know we are used to you eat your dinner late, and at the end of the day, you sleep like almost immediately, or after a few minutes, you go to bed. So most of the time, patients will come and tell you, when I eat, I go and rest, or when I'm watching TV and I reclined my seat, that is when I get this heartburn. That should be a clue you're dealing with GERD and not just dyspepsia or any other GI condition. Then again, persistent heartburn causes esophagitis, which will manifest as dysphagia. Dysphagia is usually just a pain on swallowing. And this can just be a presentation in like almost a third of the patients. So they do not have anything else. They just tell you, when I swallow, it's like that food is going down. I can even feel how that bowl of food is going down my throat. Further on, we talked about the typical symptoms, and we have symptoms or extra esophageal or the atypical symptoms. Mainly patients will present with respiratory symptoms. So think of that patient you ever saw once with a cough which is not going away. They have been given all the Montelukast, they have been given all the antihistamines, and still their cough is not going away. Think of that. The number one differential will be a reflux disease. Think of that patient who has laryngitis. Every now and then, their voice is hoarse. They are not, they just tell you they usually just get a lot of changes in their voice, laryngitis. Think of it as a typical presentation of GERD. Then in the severest form, some patients will even come wheezing. So they'll come to your emergency or your acute care setting with wheezing. When you auscultate, yeah, this looks like asthma. But when you give the asthma management according to the GINA guidelines, you giving them even the inhalers, you nebulize, but they just get some mild relief. But this patient, their asthma is never controlled. Think about GERD. When you give your PPIs, or it works as magic, that patient will never go away. They'll always say, this doctor saved my life. My asthma was just bad, it was uncontrolled. And you see again with asthma, sometimes we use steroids to manage asthma. So you could be adding petrol to already fire. So their asthma will worsen, because steroids again usually gives you dyspeptic symptoms. Then again, when you talk to some of our dental colleagues, or some people may have just very bad teeth, dental or oral hygiene. It's not because they brush, they do all the oral hygiene care, and still they are getting cavities, they are getting just gingivitis, just a lot of oral issues. Again, suspect these patients, because you see, acid is usually not a good thing for your enamel. Even when you eat, and that is why even alcoholics, people who chew cut, or people who take a lot of acidic stuff, they tend to get oral cavities, or they have gingivitis and all that. So again, those are the atypical presentation. The other typical presentation is usually, they can also get some chest pain, which is not going away, or it looks like more typical of heart issues. Then you do all those investigation for the heart attack, and it's normal. So especially the extraesophageal symptoms, be on the lookout. Again, some patients, it's not clear. They may just come with a water brush. Water brush is just where someone comes with a lot of secretions in mouth, or hypersalivation, or a feeling of global sensation. It could be just GERD, and it just presents with that. They feel like there is a foreign body in their throat, and they cannot really do anything about it. When it comes to risk factors, mostly we have what we call physiologic and pathologic reflux disease. Physiologic, as the word goes by, mostly occurs during a postprandial state. So if you attend some wedding or some function somewhere and you overindulge, probably you might, just because of the sheer, you see the stomach has a certain capacity. So if you stretch it further, the lower esophageal sphincter sometimes opens up physiologically, because usually you see the body usually has check mechanisms. So if you overfeed, sometimes your body ways of telling you you overdone it today, champ. So just next time don't do this amount of food. So it will just reflux back. So that is physiologic. And most of the time it's transient, and it will not occur during sleep. Mostly it will just be immediately after feeding, especially when you overindulge, and usually does not result into chronic reflux symptoms. So again, this is more to just show you how reflux occurs. So you have your stomach, then you have the esophagus. We said esophageal mucosa is usually different, delicate, thin, as compared to the stomach. So we have what we call the lower esophageal sphincter, which physiologically, once you swallow, the ball of food rolls down to and drops into the stomach, then automatically that sphincter is supposed to close down. But to some people, especially who experience reflux, that sphincter tone is usually either the tone is the issue, or the muscle again is also not strong enough to close completely. So again, you can have the acid refluxing, then your sphincter is normal. Then sometimes when your sphincter is damaged, most of the time the lower esophageal sphincter or the connection between the stomach and the esophagus most of the time stays open. And this is usually the cycle which occurs in patients who have reflux. So with the time, these changes, modifications occur, and it becomes even more difficult to treat these patients. So that's why we are just going through this, so that you can manage your patients as early before this occurs. In terms of the risk factors for GERD, number one is usually diet and lifestyle. Here we are talking about smoking, alcohol. So that is to people usually take about smoking alcohol. It's not just for the sake of it, because this smoking alcohol intake usually interferes with your lower sphincter tone, and it can allow acidic contents to flow upwards. Again, for people who have central obesity, so when you're meditating vizuri, sometimes as a consequence of obesity, they tend to have a GERD. So one of the risk factors is obesity. Infiltrative diseases, such as autoimmune diseases such as scleroderma, as the skin toughens, also in the sphincter, and also the muscle elasticity also changes, and that can also be one of the earliest ways of knowing whether this patient has a scleroderma or any other infiltrative autoimmune disease. Myopathies, they are also again associated with chronic intestinal pseudo-obstruction. So if you have any issues with your nerves, especially diabetics who have not been managed well, so when they get a diabetic gastropathy, again, that one interferes with the sphincter tone, and then you start getting reverse peristalsis, resulting into GERD. Some medication. So some medications, especially the ones which interfere with the sphincter tone, they will lead into muscle relaxants and all those other medications which usually relax your muscles. They will lead into that. So again, medication history is very key when you are taking history in these patients. Sometimes surgical damage. So patient was going in for gastrectomy or esophagectomy, and now after the surgery, they present with. So again, a prior surgical intervention within the esophagus or even the stomach is something else to look for. Then just esophagitis, especially for patients who have chronic illnesses, we see this a lot because of pill-induced esophagitis. So again, for these patients, when they, like your patient has a polypharmacy, so they are diabetic, they are hypertensive, they have heart failure, they have kidney issues, they have osteoarthritis. So they are taking a bunch of medicines. Be very careful not to induce reflux disease. So again, we see a lot in these patients, with, especially in our setup with physicians. Just to emphasize, obesity usually accounts for 50 to 70% of patients with reflux disease. You can see that is a large number, because that is like every 5 to 7 patients out of 10 who are obese, and that is patients who have BMIs of 30 and above. They are likely to come down with this, and 15% of those, they will also have associated hiatal hernia. Good, I hope we are together up to that point. So still on the medication, these are some of the medications, especially for you guys, you're the ones who usually dispense medicine. So when as clinicians, we get these patients on a bunch of this medicine, it's again for you to also counsel your patients. If your doctor gives you nitrates, CCBs, phosphodiesterase inhibitors, nitrates, aminophylline, muscle relaxants, beta blockers, beta adrenergic agents, agonists, all those medicines, you need to, when you are doing the patient counseling, or when you are giving your patient, you're telling them about side effects, you're telling them interactions and how to take the medicine. Sometimes also take time to see what the doctor has given the patient so that you can advise accordingly. When it comes to complications, if you do not manage your GERD well, you're likely to get a couple of complications. And these complications usually are categorized into esophagitis, peptic strictures, and what we call Barrett's esophagus. Esophagitis, as we've said, it's mainly from irritation of the mucosal surface because of the acidic content, which is foreign to the esophagus. We say the esophagus usually just handles food dropping down, and saliva usually, ideally, supposed to be alkali. Then we have loss of defense mechanisms against injuries, and this is caused by the acid in the food. So that is the HCl, which is produced by the parietal cells. Then we have the pepsin. Pepsin is usually one of the enzymes released to try and digest food. And also, some people get bile all the way refluxing. Once it's released from the sphincter of Oddi into the duodenum, sometimes when the pylorus also again is not, because sometimes when you have especially lower esophageal sphincter problems, it also cuts across. So you can get bile refluxing all the way to come all the way up to cause esophagitis. And this one you can see through endoscopy. And this is like how we usually classify esophagitis based on the endoscopy. So I'll not take much time into this because this is more technical and it's for the surgeons. The other complication is after the esophagitis, when you get healing, when you've given your patient the right medication, you've given them PPIs, you've given them the right diet, during healing process, you can get a stricture formation, and stricture just narrowing of the lumen. And this one can start giving you now that globular sensation, like when the patient is swallowing. So it's one of the complications we see at the tail end of GERD. Then the most feared complications usually Barrett's esophagus. So every other time you are managing your patient, think about the end tail of these complications. If you stay with that inflammation for long, then the epithelium or the mucosa starts changing from the simple columnar, which is usually the mucosa in the esophagus. It starts adopting to the stomach, which is the stratified. And then at the end of the day, if you don't manage, you end up getting adenocarcinoma. And that is how the lower esophageal tumors, most of them are usually adenocarcinomas. And this is the process they usually take. Starts with simple acid reflux, gets into esophagitis, gets into a change in the epithelium. And most of the time, this one is seen in patients in Caucasians, although in our setup, we are seeing a lot of this because of we've adopted the Western kind of lifestyle. And also, we are getting more data from locally. So again, it's not only in the Caucasians. People do smoke. And again, patients who have been having GERD for more than 5 years, they are likely to get into these Barrett's esophagus. So it's something we need to manage our patients well so that we avoid these complications. Right. When it comes to diagnosis, for GERD, most of the time it's a clinical diagnosis based on the straightforward, the typical symptoms we've alluded to earlier. Then if you are not very sure, usually sometimes you can do a PPI trial. So that is where our PPIs come in. So if you give your patient PPIs for at least like 8 weeks and they are improving, their symptoms are resolution, then you confirm this is GERD. If your patient has other red flags, or again, you just want to, you have the resources. You know, sometimes some of us work in resource-rich environment. So instead of doing the PPI trial, you can go straight into the endoscopy. And barium swallow, although these days we don't know much of that for GERD, but during that swallow study, when you are doing the fluoroscopy, you are able to see even your barium, which is usually the contrast media, refluxing back. So again, endoscopy, ambulatory pH monitoring, and also esophageal manometry, especially for patients who have issues with the nerves. Then they require the manometry to see. All right. So I think I'll not get much into this. This is a lot of maybe just know, especially This one, I think some of us are also doing them. Like Aga Khan, they have started doing this pH monitoring, apart from just the endoscopy. Then recent advances in diagnostic testing. For GAD, we have immunohistochemical markers. We have intraluminal impedance pH monitoring, like what I'm talking about, what we are now doing in Aga Khan. Then we have, especially for those patients who have non-erosive, these other tests come in handy, but these ones, most of the time you'll have referred to your gastroenterology where they need to do those further. So in terms of treatment, what are your goals of GAD treatment? So number one, you want to make your patient comfortable. So do away with symptoms, because most of the time patients come to us because of something, discomfort or symptoms. So when they come to you, they want that uncomfortable feeling to go away. So that is number one goal. Number two, you want to heal your esophagitis, because you've seen the cascade. Usually it starts with the inflammation, stricture, then Barrett's esophagus, then finally you get into cancer of the esophagus. So again, that is your goal number two. Goal number three is to prevent those long-term complications. And number four is you want to maintain your patient in remission as you tell them to lose weight, as you tell them to cease smoking, as you tell them to cut down on alcohol, or do all those lifestyle modification we advise our patients. So in terms of non-pharmacological, it's mostly just dietary counseling. So to avoid anything that will exacerbate that the reflux. Again, lifestyle, elevate the head of your bed into 30 degrees. So have a pillow. Don't go to bed immediately after taking your meals. So at least 2 to 3 hours before bedtime. So you have to advise your patient to be taking their meals very, very early. And then again, when going to bed, don't be in tight-fitting clothes, especially which constricts your tummy or your abdomen. And the most important, that is why it's in red, lose weight. Because we've seen in 70 to 80% of obese patients, they have GAD. So you have to look for it actively in anyone who has a BMI of more than 30. I hope that one is as simple as I'm saying it. Then when it comes to pharmacology, where I think our main discussion is tonight, medical, the mainstay is usually PPIs. So PPIs will be your mainstay. You've seen even in terms of diagnosis, even just a simple a course of PPIs can help you make a diagnosis in resource restraint. So our focus today is on the PPIs. So we have this meta-analysis from Germany. They were looking at pantoprazole. They were trying to look into when you give these patients, they have GAD-related symptoms, especially those who have, we've said we have the erosive and non-erosive reflux disease. And after giving your patient, these patients in this study, after being given pantoprazole 40 once a day, it was found to be very effective in terms of our goals, the stopping the inflammation, symptom control, and long-term complications. So we have evidence to show that PPIs work for patients who have GAD. Then again, it's another study where they were looking at esomeprazole. Again, these patients on follow-up, once they were given PPIs for some time, especially the long-acting PPIs where you're using once a day dosing, which is more convenient and also gives more control in terms of the acid. So for esomeprazole, sorry, this is the evidence. So I think I will not go much into it, but there is evidence where even for patients who have erosive the severest form of GAD, once you put them on esomeprazole, at the end of the day, their symptoms, they heal very well without even the stricture formation, and you don't get into the change in the mucosa. So again, esomeprazole has been used in the treatment of patients who are on long-term NSAIDs, because NSAIDs long-term, they can give you gastric ulcers. So again, it's safe to give them esomeprazole when you're giving your NSAIDs, when you're giving your Brustan or whatever it is you're giving. Patients who have H. pylori, again, you need to give them esomeprazole as much as you are giving the triple therapy. Then you have to continue with the PPI for some time. So I think I'll not go much into those, but this is all evidence that esomeprazole as compared to the placebo, you can see it was the way it was doing, and especially esomeprazole 40. The eradication rate or the cure rate is as high as 93.6. All right. So usually, I'm sure these ones, you guys, you're very good at this one. You advise your patient to take your PPIs half an hour before meals. Because you see, even in the process of acid production even starts even before you, just the sight of, or even mention of food, you can start even preparing your stomach. So the acid, there is what we call the brain phase of the digestion, where just mention or even sight of food, you start getting so, and that is why we usually give it even before the food, so that by the time the patient is taking their meal already, you've started suppressing the acid production. All right. So when there was a study looking at the newer class of PPIs where esomeprazole is against now the new kid on the block, the PCABs, that is vonoprazan. So these studies, you can see it was head-to-head with esomeprazole versus vonoprazan. So again, another new molecule is a bit expensive, so your patient can still benefit from your esomeprazole. The efficacy and the effectiveness is the same. All right, so I think I won't go much into that. Thank you. Back to you.
Thank you. Thank you so much, Dr. Alex Makau. That was such an informative series or informative session that we just had about GAD. So basically, there are a few takeaway homes which we will be taking. Of course, personally, I'm super impressed to learn that 17.5% of all digestive diseases are actually contributed to GAD. And one takeaway home, which I believe I want to emphasize for most of us, I hope you've heard Daktari saying very well, something which we will be advising our clients or our patients. Let's remind them, please, not to wear tight clothing in bed. Please, please, please. Those tight things should not be worn in bed. That can actually be a predisposing factor to GAD. So thank you so much for that. So of course, there is a question which, as we told you, today's session was very interactive. So there is a question which actually is on my screen here. I want to ask it so that you can type your answers there. Remember, the rules are very simple. The first 5 straight answers, those are the ones who will be picking as the winners. So answer the question and stand a chance to win the bundle. So here comes the question. What is the amount of elemental iron? Okay, question number 2. We already answered that and we got the answer is 41/5. Huh? So question 2 is name any 2 Sun Pharma brands. Name any 2 Sun Pharma brands used in the management of GAD. Let's go. In the comment section, I want to see your answers. Any 2 Sun Pharma brands used in the management of GADs. Top 5 quick typing winners will be actually winning. There's a prize for you, which will be announced in the next few. by Bernard from Sun Pharma. Name any 2 Sun Pharma brands used in the management of GAD. Yes, I can see answers coming in thick and fast. Yes, keep them coming. Robert, I see you. Jacqueline, I see you. Pan 40, Pantocid, Sompras 20. They're coming in thick, fast and thick. Sompras Luzi, Robert Mutonga, Paul Mbithi. Thank you, guys. I think that this session is very interactive. So back to you, Bernard. So you can actually, I think members are very active in giving us all these answers. They're coming in very fast and thick. So yes, we've actually learned a lot on. So Bernard, back to you. So
that is true. That is true. Thank you very much, Dennis. I want to take this opportunity to appreciate Dr. Alex Mutua for that informative session on GAD. And just to continue on that particular spirit and just to mention some few offerings which we have from Sun Pharma in the management of GAD. This particular question was just asking what brands which you know from Sun Pharma, and the answer has to be 2 brands. So we have quite a number of brands which are available with Sun Pharma for the management of GAD. We have Sompras 20, we have Sompras 40 mg, Sompras IT that is powered by Someprazole plus Etopride, and we have also Pantocid, our brand of Pantoprazole. As my colleagues are tabulating the correct answers, I want to quickly share some of the offerings which we have in a bit of some details from Sun Pharma. My name is Bernard Kipngeno, and I'm just giving you an overview of who we are at Sun Pharma. Sun Pharma is the 4th global leading specialty generic pharma company, and we have operations in more than 100 countries. We are ranked quite high in some of the key markets, and this includes US, and whereby we are ranked 13 as per the IQVIA data. And also in India, we are also the largest pharma company. In emerging markets, that is where Africa and Kenya lies in, we are operating in more than 80 countries across the globe. And we have quite a number of facilities just to ensure that we are really catering to the needs of our patients. In Kenya, that is Sun Pharma Kenya. It is the home of the Kenyans' leading brands, and that is Ranfron, which is the family blood builder, and Brustan, which is used in the management of pain and fever in adults and also in kids. This is a combination of ibuprofen plus paracetamol. We've been in the country for more than 3 decades, and we have been reaching people and touching lives since 1993 in the country. Sun Pharma Kenya is ranked 5th as per the IQVIA, and it's among the top 10 fastest growing company in the country. In various therapeutic segments, we also ranked quite high. And when you talk about psychiatry, neurology, cardiology, we are ranked quite high. In the country here, we are present in over 13 therapeutic areas with around 65 products that are available to really cater and manage some of the conditions which our patients will present at the hospital and even at your counters. We are not only giving products to your patients to help them, but of course, we're also involved in various initiatives that are very key in ensuring that we are able to contribute in our own way. And among them is the free medical camps. Of interest is the HP camps in our initiative, Anemia Free Africa, whereby we are screening patients and even giving medication free of cost, just to ensure that we are also contributing to the well-being of the country. Apart from that, also, we are catering into new patients who are presenting with epilepsy with our Live Well epilepsy kits, just to ensure these patients also are initiated and given more information. So we have this particular program called Live Well with Epilepsy, just to ensure that our epilepsy patients are also taken care of. As I mentioned, that we are having around 13 therapeutic areas which are present in the country. Of interest today, looking at the topic which we've discussed today, is gastroenterology. And I just want to mention to us that in the management of acid peptic disorders, recommend Sompras that is esomeprazole from Sun Pharma, which offers superior acid control for sustained relief and therefore offering your patients a happy tummy. It is a smart choice for superior acid control. And when you look at Sompraz, we are present across the globe in more than 23 plus countries, and we have been touching almost 1 million plus on a daily basis. These are number of patients which we are reaching on a daily basis with our Sompraz brand. It is trusted by the doctors. It is trusted by, of course, the pharmacy staff, just to ensure that their patients who present with acid peptic disorders, including GERD, reflux, NSAID-induced ulcers, they are really catered for. Why Sompraz? It is a smart choice when you are managing patients who present with severe heartburns and even reflux. It is also the smart choice when you compare with some of the PPIs available, molecules available. It actually maintains the pH above 4 for the longest period of time throughout the day. So you can be sure that whenever you recommend Sompraz, whenever you prescribe Sompraz, your patient is really taken care of the whole day. It offers higher anti-secretory efficacy, and that assures your patient that they can continue with their quality of life, even though their quality of life on a daily basis. And definitely when you look at GERD patients, it offers higher healing rates. And that is very, very important when you are managing GERD patients. Not only you can recommend Sompraz for GERD patient, but of course you can also recommend for those patients who are presenting with NSAID-induced peptic ulcers. Esomeprazole really offers significant prevention of ulcers recurrence, especially when you look at NSAID. And as Dr. mentioned, that NSAIDs are one of the most constitutive for causing of ulcers. And it is very, very important that for your patients who will be on long-term management with NSAID, that you recommend co-prescription with that PPI. And as you can see from this particular study, it shows that they are able to sustain the pH and ulcer free rate of up to 96% for your patients. So this is very, very, very important. And then looking again at the GERD-related symptoms, especially when you're talking about patients who present with GERD, there is significant improvement in GERD-related extraesophageal symptoms. And when you look at hoarse nasal sound because of the reflux, coughing because of the reflux, gagging because of the reflux, and wheezing because of the reflux, actually patients who you put on esomeprazole, that is Sompraz from Sun Pharma, they actually experience this kind of improvement whenever you recommend. You will also ask, when I give my patient 20 mg of Sompraz and 40 mg of Sompraz, do we get the same efficacy? Yes. From this particular study, both esomeprazole 20 mg and esomeprazole 40 mg offers higher healing rates when you compare both of them. So especially for patients who present with GERD, you can still prescribe 20 mg. It is sufficient enough to manage your patients. 40 mg for those severe cases, you can still go up to that level again. So 20 mg and 40 mg are available for your patients. Right now, we are offering big relief for your patients. And this actually, we listen to the patients. We listen to what you gave us as feedback. And that is why we are providing a smarter saving for your patient with up to 50% therapy cost, reduction in therapy cost with Sompraz 40 mg. Why am I saying your patient, you will be able to give them up to 50% less in terms of therapy cost is because we have reduced our trade price. Initially, Sompraz 20 mg was trading at 900. Currently, we are trading at 450 for a pack of 30s. And esomeprazole 40 mg, that is Sompraz 40 mg, it was retailing at 1620. Right now, it is retailing at 650. That is up to 59% reduction in price. This actually ensures that more of our patients are able to benefit from the price reduction. And of course, if they're able to benefit, their pockets are not getting damaged, and they are getting more saving with the same quality from Sun Pharma with Sombras. So we request that you pass these benefits to your patient by stocking a few of Sompras 20 and Sompras 40 mg at your counters so that your patient can benefit from this. Not only we are offering Sompras, we also have Sompras IT for patients who will need motility, especially you want to control acid, at the same time you want to give a prokinetic. We have Sompras IT powered by esomeprazole 40 mg and etopride 150 mg, which is a sustained release to ensure that your patient for the whole day, he is covered. We've seen that esomeprazole offers superior acid control compared to other PPIs. And when you look at etopride in Sompras IT, it is quite superior to domperidone, especially when you're managing patients who present with functional dyspepsia or gastroparesis patients. And even severe forms of GERD, you can still recommend Sompras IT. It is available and may pass these benefits to your patients. We also have our Sompras kit, especially when you're looking at the current trends where there is a lot of resistance to clarithromycin-based kits. Guidelines recommend that when there's a lot of resistance to clarithromycin, then levofloxacin becomes the drug of choice in these particular cases. So it is recommended by guidelines. It is also quite effective, especially when you're looking at dual H. pylori resistant strains, which are resistant to clarithromycin. At the same time, they're also resistant to metronidazole. The efficacy of levofloxacin-based kits, that is Sompras kit, is as efficacious and comparable to bismuth quadruple therapy. So this is the benefit your patient is getting, whereby you are really looking at cost saving for managing them with one brand without the risk of relapse, without the risk of having resistance with Sompras kit. Please recommend and also have a few at your counters. We also have our pantoprazole, Pantocid, available as 20 mg and 40 mg. We also have Pantocid IV, especially when you're looking at powerful, precise, and interaction-free PPI. Currently, a number of patients could be presenting with a lot of polypharmacy. In this current age of polypharmacy, it is very essential to give a PPI which is interaction-free with some of the other medications which your patients are taking. And therefore, we recommend that you have a few Pantocid at your counters. It offers 360 angle in terms of PPI. We are happy that now that we are having Pantocid available as 30s, just to ensure that with one pack, your patient is taken care of for 1 month, because it's Pantocid OD, 1 OD. So for one pack, they're able to really benefit. And of course, the price is $21.50 for your patient. That is a trade price. I just want to mention our legacy brands, and of course, which is there to really help your patient get back to rhythm. And in the world of Brustan, where pain and fever can really break the rhythm of the children, of the whole family, we are saying in the world of Brustan, everybody can get back to rhythm. It is a combination of ibuprofen plus paracetamol. It is combined to combat pain. And we are offering pain relief within 23 minutes. When you look at body pain, fever, headache, and even menstrual pain. Fast relief for those ones. So for the tablets, 1 tablet, and for the suspension, depending on the kid age, you can really look at that particular dosaging which we provided. I just want to mention that palatability really determines compliance, and we are offering Brustan suspension in peach and peppermint flavor, just to really ensure that our kids are not resisting medication, but with this flavor, the compliance is really improved. One thing to note about Brustan is there's faster clearance of fever compared to monotherapy, and it is well tolerated. So please recommend and keep a few more bottles of Brustan suspension and Brustan tablets at your facilities. We also have Ranfron, the blood builder for the family, especially when you are talking about kid. For the treatment on prevention of iron deficiency in kids. Every dream is important, and with Ranferon, every dream is on. Ranferon lands in my blood, and according to WHO, it recommends that there should be a daily iron supplementation, especially for kids who are presenting with IDA for up to 3 months. This is to ensure that their development is not hampered. As you can see, anemia does not only affect their health, it also affects their development. When you look at motor performance, cognitive functions, and even educational achievement. A baby who is having iron deficiencies does not concentrate in class. A baby who is having iron deficiency is psychological and development of the brain is also affected. And that is why we're saying recommend for children who present with iron deficiency anemia, please recommend Ranferon. Ranferon is powered by ferric ammonium citrate as the ion, and it has the highest elemental ion, up to 41 milligrams of elemental ion per 5 mils. So Ranferon for stronger children, for a stronger future. Not only kids can use Ranferon, but of course, even the expectant mothers. So for iron deficiency in expectant mothers, please recommend Ranferon syrup or Ranferon capsules. The dosaging for expectant mothers is 1 capsule that offers 100 milligrams of elemental iron, or 10 mils of the syrup, that is 41 mils of Ranferon syrup. It is the family blood binder. From children, infants to the elderly, they can really benefit with Ranferon. I'll mention also, whenever you get patients who present to your counters, who present with pain, especially low back pain, joint pain, muscle pain, sprain and strain, with Volini, they get relief in 2 minutes. So recommend Volini. It is powered by diclofenac, linseed oil, resveratrol, and methyl salicylate. All these ensures that your patient are able to get relief within 2 minutes of use. So Volini is there to really help you. Just as I finish, I want to say that even with Brustan and Brustan tablets, Brustan suspension, we have actually reduced price with 10%. Ranferon caps and Ranferon syrup, we've reduced price up to 18%, just to ensure that we are reaching more patients and catering to the need of our patient. With Volini, we have reduced our price up to 21%. We request that you avail this as a medicine with accessible price to your patient. Let them benefit at your counters. With that, I want to say thank you very much, and I want to welcome us to the last 4 questions for our poll. And so we had asked about which brands which we have in Sun Pharma in the management of GAD, and these are our winners. We have Robert Ogada, who mentioned. We also have Anna Wanjala. We have Grace Mweke and Esther Gadechi, and the last person who won in that particular poll question is Kennedy Kiptum. Are you ready for the next 4 questions as we finish this particular poll? So the next question, we've seen this, and the next question is, what is the strength of paracetamol or ibuprofen in Brustan suspension per 5 ml? We've seen that it is used in the management of mild to moderate pain, fever. So let's see our chat box in 30 seconds. What is the strength of paracetamol or ibuprofen in Brustan suspension? You can even refer to a bottle on your shelf if you're still at your premise. If you're still at your premise, you can refer. Yes, we've seen quite a number. We are moving to the 4th question. I'm just giving the last 2-3 seconds for the few guys who have not responded. The next question is, of course, the correct answer is each 5 mils of Brustan has ibuprofen 100 mg plus paracetamol 125. Good job for those who answered correctly. The next question, poll number 4, is what is the price reduction and the trade price for Sompra's 20 mg and 40 mg. I think I've mentioned this just a few slides back. What is the reduction we are looking at when you look at Sompra's, our brand of esomeprazole? The price, the reduction, what is the price reduction? If you can mention the percentage, at the same time mention the trade price, this will win you some internet bundles. Thank you. We've seen some choices being mentioned. I can see quite a number of us were quite attentive in that particular session. Yes. I've seen you, Nancy, Felix, nimekuona. And the correct answer is Sompra's 20 mg, the trade price we've reduced by 50%, and it is currently trading at 450. Sompra's 40 mg, we've reduced the trade price by 59%, and it is currently trading at 650 mg. Poll number 4. Are you ready for the fourth question? The fifth question is, mention the Sun Pharma brand for the management of H. pylori infection. Kenneth nimekuona, Anne nimekuona, Dominic ukondani, nani tena, Ibra, Gladys, I can see even Daniel, David, Edwin. Great. The answer to this is actually Sompraskit. Sompraskit is the brand of Sun Pharma for the management of H. pylori, and it is powered by esomeprazole, 20 mg, levofloxacin 500 mg, and amoxicillin 1 gram. It's a kit of 7 days, available with a trade price of 2,600 for the benefit of your patient. Please keep a few at your counters. Poll number 6, and I think this is second last. In Volini is used in the management of pain, especially low back pain, sprain, osteoarthritis. Pain relief starts in how many minutes? We have 20 minutes. We have diclofenac. How many minutes your patient are able to experience relief? Action starts at what? After how many minutes? Yes, we've seen. Robert nakuona, Gladys nakuona. I've seen Felix is also replying. Ayub, Lucky, Robert, yes. Some good answers there. And I'm just giving one more second. Sophie, Elijah, yes. So the correct answer is with Volini, whenever you prescribe and recommend for your patient, they start getting relief in 2 minutes. That is how fast your patients are able to resume back to their quality of life. Please recommend and please keep a few tubes at your counters to give to your patients. Especially sahi kama kuna watu wa mjengo wanapitia kwa chemist, they need to be back tomorrow to their job. They need a Volini and they need that relief. So you can recommend for those kind of pain. The last question is, what is the brand of Sun Pharma Coamoxiclav? What is the brand? This is what we've not discussed in this particular meeting, but I want to see who remembers the brand of Coamoxiclav from Sun Pharma. If you even mention what is the strength we have currently in this particular space. Yes, I've seen McKenna nakuona, Isaac nakuona, okay. Justo pia nimekuona, Onesimus, okay, Onesimus nimekuona, Julius nimekuona pia. So this is the last question as we wait for my IBC to give me the results. So the correct answer when we talk about the brand of Sun Pharma in terms of this space for the management of mild to moderate cases of bacterial infection, we have enhancing. We have enhancing 625 and also we have enhancing 1 gram. So I think Kelly, Cynthia, enhancing, Benedicta, enhancing, correct. Judith Mutai, enhancing, correct. Those are very, very good answers. And I just want to announce the winners as when we prepare to hand over back to the speaker to take care of some of the few question and answer questions that has been asked on the group. So for question number 3, the winners, when you talk about Brewston, question number 3, we have Jacqueline Kiptum, we have Pauline Mwandembe, we have Roslyn Wakungu, we have Eunice Mwikali, Julius Nyaganki, yes. Then the poll question number 4, the correct price and reduction, we have David Keegan, we have Diana Rioba, we have Julius Mwaura, we have Onyancha Kemunto, then we have Rose Njoki for question number 4. Question number 5, we have Kenneth Mutai. We also have Makena Nyamu, Anne Wanjala, Dominic Ngumbi, sorry. And again, Diana is coming again with this one of Sombra Skit, Diana Rioba. Question number 6, we have what is this? How many minutes your patients are able to get relief when you look at Volini? And the answer is 2 minutes. And the people who really got this very fast, we have Barnabas Aduda. Then we have Isaac Waweru. And then we have Onesimus Chepchieng. Then we have Nancy Buraret. Then Miriam Wairimu. These are the people who got correctly very fast. Or of course, and lastly, the last question is, what is the name of Sanpharma Coamoxiclav, which is a Nansin? And we have Julius Moura again, Anwanjala again, Eunice Abdule says. We also have Hilary Kiptum and Makena Nyam. Congratulations to all our winners, and kindly note your airtime will be given to you tomorrow morning so that you can be able to enjoy the data bundles and access more content on the internet as you read and develop yourself. Over to you, Dennis, to continue with the remaining part of the program. Thank you very much for listening.
Thank you so much, Bernard Ngeno. That was a great presentation. So I want to start by first of all apologizing to our viewers. Sorry, I know we've run beyond time. We normally take 1.5 hours, but today it has gone so much. But allow us to have like 2 minutes of Q&A. I'll just scan them quickly so that Doc can answer them. Though I've seen most of the questions Doc has actually handled them on the chat box. So Doc, there are 2 questions here which I need you to actually answer quickly. Robert Ogada asked, are there significant risks associated with prolonged PPI use? I will want you to combine that question with answering whether can NAD progress to ERD. Let's start with that, then we'll take 2 more, then we will actually close. So Doc.
Okay. Thank you, Bernard. Yeah, so long-term medication use, I think every other medicine usually has some side effects. For PPIs with the long-term use, because you see the main mechanism of action is usually reduction or inhibits production of acid in the stomach. And you see acid is usually required for you to absorb most of the elemental minerals like the calcium, we have iron, we have magnesium. So if your patient is going to be on long-term PPIs, especially more than a year, then you need to supplement some of these elemental ions like the calcium. And most of the time, calcium for patients who are taking PPIs, as much as they are not taking it together, I think calcium carbonate usually it's better because it doesn't require that the acidic environment for it to be absorbed. Then again, you also need to supplement magnesium. Again, patients who have iron deficiency anemia, you want to supplement, especially when they are off the PPIs, because again, we know iron requires the acidic media. Also for vitamin B12, again, you see for the intrinsic factor and all that to be produced, although PPIs do not impact much on the B12 absorption, but it's something else too. Also, think about it. So I also saw a question about osteoporosis and PPIs. There is a relative risk of osteoporosis, especially for postmenopausal women, but that is the risk is minimal. And again, it's thought to be through the mechanism of inhibition of calcium metabolism and vitamin D. So again, relative risk. And I think in the presentation, there was one of the studies where it was looking at the same, and they found there was very minimal, especially if you're using for less than a year. Then the other question was about what again?
GAD and NAD. Can
Yes.
it was GAD and NAD, yeah.
Yes. To some patients, when they stay with the reflux disease for long, it can progress because you said it's usually like a spectra. It's usually a spectra. So initially it can be just non-erosive, but if it's not recognized, managed, it can proceed to erosive. Yeah, thank you.
Okay, thank you. Then the last questions, Daktari. How long should a patient ideally remain on PPI therapy before reassessment? Then also I need you to combine it with what you already answered on the chat box, because I feel like it's very important for viewers to actually know this. One Julius Jakangi asked, what can be done to reinforce the lower esophageal sphincter to avoid acid reflux? If you can combine the two, we can actually finish the Q&A session gladly.
All right. For the less or the lower esophageal sphincter tone, most of the time it depends with it's dependent on the having a good nervous system. And again, also we talked about things like obesity, because you see in obesity, most of the time your muscles also tend to be a bit you get what we call like sarcopenia. Your muscle strength and also the muscle mass usually gets low. So if you exercise, you as you lose the weight, you also tone up the muscles and also you improve on the lower sphincter tone. Again, for patients, because we said like 15%, we said 50 to 70% of the patients with obesity will have GAD, and about 15 of them usually they have associated hernia, hiatal hernia. So usually have what we call surgical interventions. So we have the NIAS operation or sleeve gastrostomy, where they usually try to mobilize or try to usually restore the lower esophageal sphincter. So it can be done surgically. And again, once you avoid the risk factors, especially the medicine, we talked about a list of medicine, which usually predisposes you to getting GAD. So if patient is on those muscle relaxing, or patient has like those infiltrative diseases such as scleroderma, then you control the condition and the sphincter function improves. All right.
Thank you. Thank you so much, Daktari. I think we've done well, and that marks the end of Q&A session. Thank you so much. So I think for me, the takeaway home was when you talked about patients coming to our facility presenting with cases like asthma, kumbe us, we think that it's a different condition. So we need to be very, very careful when we are tracking patients and when we are taking notes. You might be thinking that you're managing ulcers, kumbe it's GAD. So let's also be careful with that. So, dear members, as we come to the close of today's webinar, I would love to sincerely thank our partners. First of all, allow me to thank Sun Pharma. Thank you for this webinar and your spear sessions. It's always very informative and very interactive. We appreciate for today's episode. We are on episode 5. Thank you for that. Also, I want to thank Dr. Alex Makau Muia. Your session was so interactive. It was we learned a lot. We picked a lot from it. To the KPA Rift Valley branch, thank you also for organizing this. Your members or us as your members, we've remained informed and updated about development in the medical world. And this is something which we would actually request that you keep on doing for us members so that we can continue learning and bridging the gap between what we do to our patient and what is actually happening in the medical field, as it's a wide field which keeps on growing as technology also advances. And finally, I want to thank the greatest stakeholder in this, who are us, the participants, the pharmaceutical professionals who spared their humble time to actually join us tonight to be able to learn and interact with us in this session. Please just remain patient. We will be posting more sessions, and remember to continue joining us as we continue to offer such informative sessions. Thank you so much, and I'm wishing you a good night. Keep safe. Remember, World Cup is starting. Select your team wisely and be happy. Keep healthy, keep safe. We are officially off. See you next time. Kwaherini.
Thank you and good night.
Good night.